Jay Kempton. I'm co-founder of the FMMA, and I've got we're gonna have a wonderful panel for you all this morning. This is a case study on Tower Extrusions. This is Mark McClelland from Tower Extrusions, the CEO, and then also Laurie Burke with the Burke Company, and she is their consultant. Laurie is an independent consultant, and actually your history was you were a TPA owner for some time. Yeah. Recovered, living a better life, getting more sleep, all the things. But Tower has a wonderful story, and I'd like to maybe start, Mark, if you don't mind, just to tell our audience a little bit about Tower, about what you do and how you look at your benefit plan, and maybe also a little bit about your environment and where geographics and the dynamics in your area.
Sure, be happy to. So to tell you a little bit about us, we are a heavy manufacturer. We make aluminum extrusions, and we're located about 2.5 hours south of here, south of Wichita Falls in Texas, and we have all of our operations, or almost all of our operations, are in Texas. And so, I'm one of these guys. I don't know a whole lot about, healthcare or benefit plans. You run a business. It's kind of one of those things you have to do. But, I can read financial statements, and I know my employees very well. I know whether they're happy or not happy with our healthcare plan, right? So our story is so interesting, the way it started out. And as I was kind of reviewing it in preparation for today, it's really amazing when you think about what all we've been able to do. It all started, I don't even know, Laurie, when we first started, but the first thing we did was we hired Laurie's TPA firm. And I was a bit of a rebel. I didn't have a broker. I just was doing things with TPA firms. And little did I know what I was getting when I met Laurie, because she's been my guide through this whole process. So we started out with her TPA firm, and then she started the whole process of educating me on the various methods available to provide benefits for our employees. So I think it started back in about 2012 when she first came to me and uttered the words reference-based pricing. It's the first time I'd ever heard of it. She sat me down. I think maybe you had to bring it a couple of years before you actually got me to buy in. But, I really trusted her by this time. And so we jumped off in around 2012 into the reference price based pricing model. We were, of course, self-funded. And, our costs really went down, and they went down fast. And back to the financial statement, I love that portion of it. And I will tell you that 95% of our employees love the experience. However, we had some immovable forces in our provider network that we really were trying very hard to steer away from, but the inevitable happened, and we ended up with several, 2 or 3 balance bill cases that were, quite nasty. And I just didn't get, I didn't like it. I was spending a lot of time with these employees that were having to deal with it, and we were funding it all and providing all of the help. But after 3 years of this, in spite of saving a ton of money for both us, for the company, and for the employees, I pulled the plug on it. And based solely on the experience of a few of our employees that were direct billed and just in a tough situation. And, Laurie put up with me. Our costs started to climb significantly after that. And it wasn't too long after that we were back in a regular PPO system. We make some acquisitions in Dallas. And you have to know our business. It's heavy manufacturing. It's tough guys in the back of the plant, a lot of hot days. It's hard work. And, a lot of guys that aren't necessarily going to go do their wellness exams every year. And so in the middle of all this, Laurie really helped us to get our wellness program going. And I'm maybe as proud of that as anything. We really started that, changed the culture in the company, and in fact, I'll point them out over here. I got a couple of wellness nurses here in our 2 locations that make this thing go because they're the mother hens. They set up a lot of the, when was it, 2017, I think, when we started, is that right?
Yeah.
Somewhere around there with KPP Direct, which if you guys don't know what that is, you need to find out about it. Maybe Laurie will tell you. But our 2 wellness over here, Shauna and Jonna, just really direct patients great. They set up new providers, and they mother hen our employees. And so anyway, after these acquisitions in Dallas, we bought into some really a really bad situation as far as our healthcare costs there. So Laurie comes back to me and she says, Mark, you remember the RBP system? We're in Dallas now. There's more providers. And boy, the costs were so out of hand. She really convinced me. And so we go back into the RBP market. And it worked so good. She eventually encourages me to go back into the RBP plan in our, let's say, Wichita Falls plant, because things had changed there. There were some more people. We weren't in the battle alone anymore. And I guess if anything, that's the message I want to bring. I've watched this thing evolve over the last 13 years that we've been in RBP systems. Is there's power in numbers. And so for any of you guys out there, I'm going to turn this thing over to Laurie and she can give you all the details, and that's what you need to hear. But the one message I want you to hear is, if you're considering going to a reference-based pricing model, come on in, because when we started, the water was really cold, and it's not warm now, but it's lukewarm. It's not freezing anymore, right? But as more people get involved in this, I promise you, there's strength in numbers, and it works. So we're to the point now, and I can tell you, after 13 years of this journey with Laurie as our guide, we have saved millions of dollars. We've saved our employees millions of dollars. We have a system now that our employees really love and they're proud of. It's still not without challenges. I'm not going to tell you there's not some challenges there. But through Laurie, through working with Kempton, we have a benefit plan in our healthcare system that I am really, really proud of, both financially, both as the level of benefit. And it's through all that we've done, we've really changed the culture in this He-Man manufacturing plant that we've got, to where now, John, I'll go by her office sometime and she's in there, lecturing, a 60-year-old worker about how he's not doing right with his, diabetic medicine, and she's got him in there, and we have a great culture, and we can see it. There's so many intangibles, the health of our employees. And so I encourage you, if you're thinking about going down this route, come on in. It's a lot easier now than it would have been when we started 13 years ago. So I'm going to turn it over to Laurie and let her give you some of the details.
So the problem with RBP was not the savings, not the reserves that they ended up with in their account. The problem was that with their headquarters in Olney, Texas, the only level 1 trauma center was in Wichita Falls, about 45 minutes away. They pretty much had a monopolistic lock on the market, to the point that you could not send your child to a middle school or high school sporting game without there being an orthopedic specialist from a facility we will call unreasonable hospital on the sidelines. And as one of the Tower executives said, that's not healthcare, that's marketing. Exactly. And so they were intractable, and it quickly became a tit for tat. And Mark, I'll let you advance. We sent our employees, most places it worked pretty well, but when they got to unreasonable, there would be a balance bill issued. So Tower said, we'll fix this. We'll put on the check, if you accept the plan's payment, you've been paid in full for this episode or event. And Unreasonable said, we'll return the check to Tower. And we're going to turn around and bill the member. What do you think of that? Tower said, well, then I'll issue the payment to the member and you can get it out of them. And we went back and forth. You can appreciate that in the meantime, they're having to bring employees off the line and try and explain in bilingual language what's going on here with the balance billing and so forth. And no, you don't really owe that money, but et cetera, et cetera. It ended up in a standoff. Tower wanted to send its employees elsewhere, but really didn't have another option. And it wasn't really working to say, just ignore the balance bills. And Unreasonable for their part is not cashing the payments and then just auto-churning bills to the members. And we ended up in a bit of a standoff. Tower blinked, as Mark said. The savings were great, but the hit to the reputation of the plan and the members' feelings that I really don't have good benefits, that Tower's trying to do something with Medicare, and Medicare's for old people, not for me. It just wasn't working. And so they had to go another way. We did go back to and I will tell you that we eventually resolved the claims with Unreasonable at 60% of billed charges. And to translate, that ended up being about 240% of Medicare. So you could argue that Tower won the battle a little bit in terms of cost, but certainly lost the skirmish when it came to the hit to the plan. So back to a carrier PPO, which had a PBM that came with, which is another breakout session or two, but you can appreciate that cost doubled. I have to confess the carrier PPO is not the only thing going on in those red numbers. As Mark said, they had made some acquisitions. And some of those tall red numbers are the proof of concept for having the long-running health management program and focus on managing your chronic conditions and the nurses on site, because the acquired facility did not have the experience of the cultural seepage of that health management program. And it wasn't until along about 2019, 2020, when did you, Shauna, 22. Okay, so all of this is without benefit of an on-site clinician, and proof is in the pudding there. I think we're ready. Yep, I think we're ready to go. Okay, so the question becomes then, with costs going out of sight, is it safe to go back in the RBP water? And Kempton was helping with that presentation, but Tower's answer was, as long as you do not have an answer for Unreasonable, back over here with 2/3 of our employees in the only headquarters, I just don't think enough has changed. And I distinctly remember Mark saying at a renewal meeting, Kempton is proposing a 7-figure savings in the health plan, and it takes a lot of aluminum to offset $1 million savings in my benefit costs, but you haven't convinced me that enough has changed that it won't hurt the plan and it won't hurt the members again. So it took a couple of 3 years this time for sure, and what changed things was the additional options, the movement of KPP-free providers and others in the free market direction, some direct contracts with a whole hospital system in DFW and some smaller regional facilities, some really hardline anesthesiologists been bought out, moved along, so more work to do there, and some specific progress. A free market broker who actually sat on the board of Unreasonable said, I'm kind of wearing two hats here, but I'm telling you, you're hurting your business and you're on the wrong side of this one. Made a little headway. And so Unreasonable grudgingly said, all right, we'll do a direct agreement at a token amount off billed charges and live happily down there. The transparency laws helped Kempton to say, okay, now we can do a little parsing of claims and dollars in advance of your going there instead of looking backwards. And when we looked backwards in the old days, Unreasonable was charging about 400% of Medicare, except for those things where they were charging 1,200% or more. Well, Kempton took a look at the charges here and said, overall, this looks like it's going to come out to be about 300% of Medicare. But if we slice this a little differently, we will tell you that it's not that bad on inpatient care, where they're still really egregious, as you can appreciate, radiology, imaging, and emergency room. So if we're selective in how we use unreasonable, maybe this will work. And we can transparency laws have helped in that sense, in that we could take a better look. Okay. Surprisingly, the problem then was not in only, but in DFW. And the second time we went RBP, after they had the acquisitions, all of a sudden there's blowback in DFW. Why is that? And the answer is, kind of in a good way, the free market movement has moved enough that in the major markets, the Baylors and the Texas Health Resources are feeling the need to absorb all those little surgery centers and outpatient clinics and specialists. So places where we used to go and not have a problem, now all of a sudden are saying, we don't take open access plans. So the solution became, and it was an interesting survey of the marketplace and where we were last summer when Tower said, we got to do something else. What do we do? And surprisingly, what we ended up with is a network, but a network built right, specifically in the form of healthcare highways. Healthcare highways brings some things to the table that you can appreciate the carrier PPOs do not. They have some contracts with Medicare Advantage plans that require them to meet time and distance locales, so they've got the breadth there that you need. They specifically target those facilities that have not been swallowed up by a Baylor or what have you. They've got some other RBP resistant folks in the network, et cetera, and they're super competitive pricing and a real willingness to work with the group and understand that our objective here is not steerage. Our objective is access for our members. So next slide, last slide.
Laurie, I might make one more quick comment on healthcare highways. Everything that Laurie said about them is absolutely true, but I also want everybody in the audience to understand that that's not how they always were. This is a network that is independent, but they have also been somewhat curious about what we do here at the Free Market Medical Association, and they have attended. And I would like to say that this movement has caused healthcare highways to see the future somewhat, and where they can be a network that is also friendly to other free market causes and employer direct contracting. So I got to give a shout out to healthcare highways that networks can be part of the solution if done right.
And there were some other network stories that, sure, we welcome you, but if you want Baylor in the network, then you can't have an RBP wrap. So we appreciate healthcare highways there. It worked, and I will tell you that the big number dollar in 2024 is not because the RBP plan did not work. That there are 3 premies and some other things going on in that 2024 number. But I will also tell you that even if we take the $902 PEPM, we're at $10,000 and change in overall medical costs. The national stat is closer to 15. And if we work off the $641 or whatever, that would have been closer to about half what they're paying nationally. So just to wrap up, we better, again, it's not about the dollars. One more slide, please, Mr. McClelland. Unreasonables billing started at 400%. The direct agreement gave us 300%. But if you go back and look where the nurses are sending them for care or not, we're actually paying in the 200% realm. So that's a true win. The employees are sharing in this. Not only if I'm all in on the health management program at Tower, I can be a member of the health plan for $2.35 a month. Not a bad deal for employee premiums. but a huge difference in employee cost sharing. Nets out to $370 per employee. If you go back to the stats, we've all heard about how over 60% of us are not able to handle a $500 medical emergency, and that 41% of Americans are carrying healthcare debt. That $370 for every employee is a huge deal. Tower is not different from a lot of other Texas employers. They have more than 100 members who are taking diabetic RX, which means they have a diabetic diagnosis. And yet, the high dollar claimants, only 4 of them on that list are there because of chronic conditions. These guys are good and fierce advocates, but they can't cure cancer and they can't fix preemies yet. And there is one member that, having had the pleasure of working with Tower for such a long time, she's been on the list for years. $10,000, $30,000, $50,000, $60,000 in healthcare expenses. She learned a very hard lesson this year. It cost $305,000. But she had a Betty Davis moment. I do not want to live this way. And the case manager said, not a problem, because you cannot live. You will not live if you continue this way. There is a path out, health management program, diabetic management program, and so forth. I don't think we're going to see her on the high dollar list again. So that's the canned part. I don't know if we left any time for questions or not.
How large is Tower, employee-wise?
Total, we're about just a little over 1,000, and domestically we've got some satellite operations in Puerto Rico and everything that we're just starting, but in Texas we've got about 1,000.
Yeah, because I'm wondering at what employee count an on-site nurse might make sense.
Yeah, I know. That's one thing I was saying as we were presenting this. I'm thinking about what if there's people out in the audience that have 30 employees, right? And you're saying, well, how do I afford a wellness nurse? And it is difficult. We started when we probably had, gosh, Laurie, help me. We were probably in the 400 range, 300 range. Yeah, that's probably right. But I'm going to tell you, the payback is tremendous. So I don't know. I mean, what I would advise, if you were a 20 or 30 employee, if you could co-op with some others around or something, it's a huge benefit. I'm just telling you, we've learned a lot, and I'll give you my number afterwards. If you've got questions, call me. And I'll be glad to tell you what we've learned through this. Yes, sir.
As the healthcare hospital system has to disengage with their current employment over time, hopefully with policy changes, you have a lot of extenders who these nurses are what have a position. We reference them as extenders. And that's different at states. Some states are independent. But my point is it's affordable. If you got 30 employees, ask yourself, would I hire one employee at the cost of an employee to help us manage? So in other words, we're going to have our own internal doctor. I think that's called corporate employment contract. And I'm a DPC doctor, and I'm just a block away from a big bank, and we offer an urgent care access contract, which is just very basic administrative fee once a year. And if your employee comes in here acutely, we'll just charge a flat rate per visit. I mean, there's lots of ways to leverage our providers. And again, unfortunately, the government, being the biggest payer to our hospitals, and in collusion, as we've saw from our lectures today, they're basically controlling all of this, and then unfortunately, the hospitals are buying everybody up because that's the incentives that they would given. It's all about survival for them. But again, if they change the rules and say we're not going to give you facility fees anymore, they have to let go of almost everybody that they employ that is a healthcare provider, and that will get huge.
And probably it's definitely worth saying that, for a small employer or even a larger employer, if direct primary care is an option, then it suffices for a lot of what Tower has done internally. in only Texas, they don't have a whole lot of direct primary care options available. And so they went, the employed nurse route. But I didn't want anybody to infer that Tower would have looked at DPC if it was available.
And I think a significant part of what these guys are doing is not just medical care, but again, marketing, advertising, Tower's interest in their health, Tower's benefit resources. So you have to ask them, but 99% of their time is navigation, referrals, helping folks move through the system and get to the benefits, as opposed to actually providing medical care on site, although they do some of that too. And I would take, even before you've reaped the kind of savings that you can do, I'm certain that Tower has gotten many times the return on investment, which is why they have a team of, for 1,000 employees, have a team of 8 clinical and HR professionals and counting. I think that ratio really works for them.
Speak of the devil, Healthcare Highways just walked in the door. Kelly.
Yeah, thank you, Mark, for being a very courageous employer. Boy, break through the stats so bow, do what you did many years ago. But you think about your benefits, your actual benefits, your deductible, your copay options. Can you describe, and maybe you did that, I missed it, but that's the case, I'm sorry, but can you describe what those benefits look like on the deductible side and the copay side, and have those changed over time very much?
You're probably better able to answer that than me.
The premiums, Tower has been very generous for a long time. If you meet all of the parameters of the health management program, you get $150 a month off your premium, and your spouse can do the same, adults on the plan. For an employee, that used to drive your premiums contribution down to about $35. It's with RBP that it's gone down as low as $2, and that really tough year, it's going back up to $10 a month. Copays, pretty typical copays, $35 for most visits, $300 for emergency. The cost sharing is pretty much 80-20. Having said that, I don't have to be very sophisticated. I don't have to take very much of Jana or Shauna's time to navigate my way through Tower's health plan with darn near zero out of pocket. Free telemedicine, free KPP events, free health fair and concessions, free maintenance meds for my chronic conditions, including diabetes, including GLP-1s, free medical services if I will take the time to ask them to direct care where those resources are. So I could get an awful lot of my health care out of the Tower plan without spending a dime for my whole family. $2,000 deductible, out of pocket max, $6,800 something. Yeah. Real small. And that we talked about the savings per employee. The out-of-pocket on medical spend this past year was collectively $560,000, down from the 22 peak of almost $900,000. So when you're talking about employees, that's real money. Yeah, families.
Okay. Well, I think that's a wrap. We've got another session to go to, and then the Beacon Award. So thank y'all.